The following podcast is part of a certified educational activity titled RCC Treatment Innovations in Practice, Preparing for Individualized Patient Care. Access the entire activity and complete the post-test at peerview.com/JUG860. Downloadable slides and practice aids are also available.
All right. Welcome, everyone. It's great to see you all here this evening. I am sure we're probably going to have some folks getting in a little late, some late stragglers. I'm sure there's a bit of traffic coming in from the conference center, so we'll be obviously prepared for that. David and I actually just got off the stage at ASCO and just rushed over here. I'm glad we got here on time. We have a really exciting program for you today. We're going to talk about treatment innovations in practice in kidney cancer. I have two amazing panelists here. Let's see, my clicker is right there. Okay, and I'm really thrilled to have my dear friends Dr. McDermott from Beth Israel and Tian Zhang, who's at UT Southwestern. So we've got a couple of goals today. We want to provide some insights on the latest safety and efficacy data. We have a lot of updates actually just from earlier today, in fact, that we've managed to incorporate. We're going to equip you with strategies for personalizing care and provide you with some approaches to manage side effects associated with treatment. KC Cure has been a really vital partner in all of this. Really grateful to them. Providers should be aware that patient perspectives are really key in terms of how we go about our day-to-day business, and we're going to try to incorporate that feedback and surveys that have been done by KC Cure throughout the course of tonight's presentation. And with that, I'll turn it over to Dr. McDermott.
Great. Thank you, Monty. It's good to be with you again, and Tian, always great to see you. I was asked to talk about optimizing first-line therapy in kidney cancer, talk about some of the evidence, focus on some efficacy, and also how we strategize for our patients to make sure what we're doing is patient-centered. And so let's start with a case. We have a couple here. The first one is Marty, who is a 67-year-old male who presents with 3 years after nephrectomy. He has pulmonary metastases, but fortunately he's asymptomatic from these. He also has a solitary bone met in his iliac crest, which is a non-weight-bearing bone. And when you ask Marty what are his goals for the future, he's looking for a durable response. Then the second case is Janice, 72-year-old female. She has a more aggressive disease than Marty. She presents with multiple hepatic metastases from early onset following nephrectomy. Her goal is disease control. There are probably few areas in solid tumor oncology that have seen more progress over the last decade or two than kidney cancer. We've gone from an era where we were giving cytokines and chemotherapy didn't work and there were very few options and the survival was not much beyond a year, to then moving through in the early 2000s, the era where VEGF-targeted therapy began improving outcomes and lengthening survival. And then about 10 years ago, we entered the era of immune checkpoint blockade, so a more modern immune therapy for our patients, which was both more active and less toxic than prior approaches. And that was given for patients who'd failed VEGF TKI, so the initial approval of Nivo was for patients who'd failed VEGF therapy. And essentially, the last 10 years have been essentially a fusion for many patients in many trials of the old first and the old second-line therapy with IO-TKI combinations. And we've also been adding to PD-1 with CTLA-4 blockade, or the sort of dual IO approach, in hopes of improving benefit with both approaches to PD-1 blockade, essentially trying to enhance the immune response to the patient's tumor. And we've seen dramatic improvements in survival since that time, which is encouraging for our patients. This is the PD-1 CTLA-4 approach of Checkmate 214, which is Ipi-Nivo. What we're showing you here is the data from the intermediate or poor risk population of patients. This was sort of the primary endpoint was centered around this group, although good risk patients were enrolled. And you see, several trends that have continued. So essentially, this update looks a lot like the last update, where the overall survival curves continue to stay separated between Nivo and Ipi, with the hazard ratio of 0.69. Progression-free survival curves, importantly, also staying separate, with about 25% of patients who have yet to progress on this therapy. And for duration of response, so the response rate is lower with PD-1 CTLA-4, but if you have a response, there's about a 50% chance of that being durable for over 8 years. So that's what's probably driving the plateau you see in the PFS curves. So let's, with that sort of shape in mind, we can also look at the ITT population. So this is adding in those good risk patients, and essentially the numbers look pretty similar, although some differences. The OS curves are staying separate. The PFS curves are separate, but maybe slightly less so, and the duration of response is still impressive. And about 20% of patients receiving Nivo/Ipi discontinued therapy and did not receive subsequent systemic treatment. So essentially, those patients are living with their cancer under control and off therapy. They're essentially living in remission of their disease, which is this concept of a treatment-free interval, or when you look at the entire group, treatment-free survival, which we'll talk about in a second, which is the goal of many of our patients. It's not just to live a long time, but ideally to live off therapy. The NCCN guidelines have actually been extended. They originally just covered the intermediate and poor risk group, but now they favor this as a regimen for even favorable risk kidney cancer based on this data. So not only do you see improvements in overall survival and duration of response, PFS, but you see improvements in response rates and ongoing responses between the arms. Once again, the response rates in the ITT population with Nivo/Ipi are not as high as you see with IO-TKI, close to 40% here. But there are more CRs with the combination, and many of those responses, as we've talked about, are ongoing. The deeper your response, the more likely it is to continue. So you see the ongoing CRs, 80% of those patients have yet to have a recurrence. And that's a concept that we've seen across immune therapies for solid tumors. We've not just seen it with Nivo/Ipi, but we've seen it with CTLA-4. We've seen it with high-dose IL-2. Those deep, durable responses often last, leading to remissions for our patients. So, when you look at this, sort of the summary for the 9-year follow-up for CheckMate 9ER, this is what's going to be presented tomorrow, and it looks pretty similar to the 8-year data that I just went over. This is the longest follow-up for any trial, so interestingly, most of the other comparators in this space have stopped looking at their data after 5 years. Now we're up to 9 years with Nivo/Ipi. And you see, generally what you'll see tomorrow if you're attending the meeting and attending this session, you'll see, continued encouraging hazard ratios for overall survival, staying pretty similar. Same thing for progression-free survival, and the hazard ratio for the favorable risk is interesting because at the time of the primary analysis, this hazard ratio for favorable risk, was above 1, and now it's less than 1. And looking at the landmarks for overall survival from the abstract, you continue to see differences in both the ITT and the IMDC subset populations. There's also been no new treatment-related deaths occurred on either arm, no new safety signals. And Dr. Motzer is going to produce some subgroup analyses as well. This may be the last time we see this data analyzed, but it's great that we're actually talking about clinical trials where the follow-up has lasted 9 years in kidney cancer. It's really a lot different than where we were 20 years ago. So whenever talking about any immune therapy, you have to focus on both the durable positive news, which we've talked about, but also the durable negative news, which is, not just the positive effects can continue, but so can the side effects. Autoimmune side effects are more common when you add CTLA-4 to PD-1. They're more likely to be severe. They're also more likely to last. One of the things that is interesting about the Nivo/Ipi regimen is that most of the side effects people experience, as shown on this graph, is they happen relatively early. In the first months of treatment, they generally stop occurring after the first year of treatment. So even though you can continue the therapy, you're not accumulating side effects, which is obviously very different than, say, with chemotherapy or ADC targeted therapy, where side effects build and patients often get discouraged and want to come off treatment because of side effects. That's less common here, at least in part because much of the regimen is just PD-1 alone after the first 4 doses of the combination. So the side effect management is a little bit easier after you get beyond that 12-week period. So, one of the concepts that I mentioned was this concept of treatment-free survival. This idea, came out of something we were working on to try to measure, as I mentioned before, both the positive and the negative aspects of, immune therapy, and to, just to focus on how do patients spend their time alive after immune therapy in the different parts of that time. So what treatment-free survival is part of what we call a partition survival analysis. So on these curves, the purple part of the curve is the time that patients spend on protocol. The blue is the time they spend off treatment in treatment-free survival. And in the gray area of that survival curve is survival on subsequent treatment. And this is an interesting way, we think, of comparing the pluses and minuses of these approaches. And what you see when you compare nivo/ipi in the intermediate and poor risk group to sunitinib is differences. You see, in general, more survival with nivo/ipi, as we've discussed. Time on subsequent therapy is much greater for patients on sunitinib. That's probably because they're being salvaged with PD-1-based approaches. Treatment-free survival clearly favors nivo/ipi, largely because patients in response can live off drug and in remission. And time on protocol therapy tends to favor nivo/ipi as well, slightly. So you can see the pluses and minuses. Also, those hatched areas are the areas you spend with toxicities. So, in general, patients spend more time on sunitinib with toxicities, but the time they spend on nivo/ipi is probably spent with more serious toxicities. And some of those toxicities continue over even during the period where treatment stops. So this is a way we think of talking to patients about how this entire group experienced their treatment and how a patient going forward might experience in both the positive and the negative of these approaches to help people make decisions, from the time that they present, like the cases we described. So when you think about the sort of my general thoughts on the long-term data with dual IO, PD-1, CTLA-4, we've seen improved survival. We've seen the longest follow-up. Obviously, if you respond, there's over a 50% chance you'll stay in response. There's a potential to stop treatment, which lots of patients want to do. And during that time, they experience improvements in quality of life. We haven't covered this, but patients, in subset analysis, we've looked at different histologies that are more or less likely to benefit. The data with sarcomatoid kidney cancer, which traditionally was one of the most lethal forms of kidney cancer, is actually very impressive with nivo/ipi, which is great for those patients, and it becomes sort of the primary go-to for those patients for most clinicians. But there's a downside, which is there's a higher risk of serious adverse events, the immune-related adverse events, and there's lower progression-free survival or response rates. So there's more issues with cancer control. So if you have a patient who is quite symptomatic from disease, you need a rapid response. Nivo/ipi may not be the best way to go. So I'd now like to try to switch to the other alternative option, the other PD-1-based option, the so-called IO-TKI regimens, which have some similarities but also some differences, which I'll try to highlight. The first of which that received FDA approval was the KEYNOTE-426 study. And what you see, with the data now that we have a longer follow-up, about 5 years of follow-up, here with pembrolizumab and axitinib, you see the clear improvement in progression-free survival has been maintained with a hazard ratio less than 0.7. And you can see the clear separation of those curves. So we're focused a lot on the shape of these curves because they're important for practice. Those curves, unlike the nivo/ipi curves, which don't separate for a while, these separate right away. suggesting you get better disease control at the beginning. And overall survival, though, is also interesting. A clear overall survival improvement, at least initially, but those curves start coming together over time. Now, it is true that all survival curves come together if you follow patients long enough, but these come together, within this, 5-year period. They start moving somewhat closer together, with the hazard ratio of 0.84. So remember these curves, remember these numbers as we talk about some of these other data that I'll go over in a second. The other part of this, of this slide is response rate. And you can see those numbers much higher with ACPE than Nivo/Ipi, that overall response rate of over 60%, with almost 12% of patients in CR. Getting to this issue of disease control and rapid tumor shrinkage, which certainly favors ACPE. Another option for our patients that came after ACPE was the combination of Nivo plus Cabo. And you see some similarities in the Nivo/Cabo data compared to the ACPE data, but there also are some differences. So for example, progression-free survival, a clear, impressive improvement in progression-free survival. Once again, those curves separating early and staying apart with a hazard ratio less than 0.6. And overall survival, those curves also look somewhat similar to the ACPE curves, clear improvement earlier. And as we get to 4 and 5 and 6-year follow-up, you get some coming together of those curves. The hazard ratio also close to 0.8. A significant improvement in response rate here, favoring the combination, not surprisingly, with an overall response rate close to 67% compared to what we saw in the sunitinib arm, much higher overall response rate and a CR rate, which is what patients are looking for. The clear data came last, but is also rather impressive when you see the sustained benefit with Pembro and this time lenvatinib, which is probably a more potent TKI and has more targets than exitinib. Here's with a median follow-up of 50 months. See the best in class if your focus is on efficacy numbers. Not that we should be comparing these head-to-head, because we don't have head-to-head data, but a hazard ratio here less than 0.5. Clear those curves are pretty separate. There were more good risk patients on this trial, so that compared to other trials, so that may possibly explain some of these encouraging numbers. Once again, the hazard ratio for overall survival about 0.8 at this point, and the highest reports of overall response north of 70% with this doublet. So several encouraging options for patients who are looking for good disease control. One of the issues with managing adverse events when you're talking about IO TKIs is the overlapping toxicity. There are some that are driven by just the PD-1 and others just happen from TKIs, but some are overlapping like rash and diarrhea and hepatitis, meaning they could happen with either drug. And so this creates a little bit of a challenge in the clinic about which one of the two drugs that you're giving a patient is driving the side effects. Sometimes the easiest way to figure out which one it is to stop the TKI. That's easier to do probably with exitinib because it has a shorter half-life, whereas some of the half-lives of Cabo and lenvatinib are much longer. But we encourage people to hold treatments, and in certain cases, with supportive care, the symptoms will resolve quickly. Then the TKI is the cause, and unlike IO, the side effects usually resolve much more quickly with these regimens. When you think about sort of the thoughts on the long-term data with IO TKI regimens, there's certainly pluses, improved OS, higher response rate, longer PFS, lower IRE rate, but there are some downsides and potential for chronic toxicity and overlapping tox being on that list. Just finishing up in the last few minutes that I have, talking about a new entrant into this space, which is the potential of sub-Q PD-1, which we're going to hear a lot more about at future meetings because it's going to become a lot more prevalent. This helps us improve the daily management of patients. It's an alternative that benefits both the patients and providers, and for several reasons. One, you don't have to deal with IV sticks or ports. It allows the patient a little bit more flexibility. There's reduced times of preparing the dose and administering it, so you can have more time for patients in the treatment area. And it optimizes the occupancy of infusion centers because it's easier to give. There's potential in several agents in this space, both with sub-Q, Atezo, and Nivo, and there are several sub-Q studies underway with pembrolizumab. So we're going to be hearing more about this in this space. It looks like an active approach. There's no increase in toxicity, so there are definitely advantages. A lot of this was driven home by the Checkmate 067 study, which was Nivo sub-Q, and essentially showed that it is non-inferior to Nivo IV based on PK and overall response rate, and you can see the benefits as it relates to administration time. So a future option for our patients. So when you think about safety and implications for Nivo, it's probably going to be more favorable in many ways. And now the NCCN guidelines are being updated. Just a couple of words about the status of biomarkers for kidney cancer. KIM-1 is a blood-based test that seems to go up in several scenarios, making it potentially attractive for managing patients, both deciding who should get adjuvant therapy and when metastatic disease is working or not working. So we're going to hear a lot more about this, and hopefully we can validate KIM-1 as a biomarker going forward for our patients. There was interesting data presented by Monty on KIM-1 at the clinical science session, which maybe we'll talk about later. There's also interesting data from the Checkmate 9ER study, which looked at potential predictors of response and resistance. It seems like there are certain factors in the microenvironment of the tumor that drive resistance and response. So for example, Tregs driving resistance. For example, tissue-resident macrophages driving response. So we'll hear more about that at future meetings, including data on the extracellular matrix. And when you think about patient priorities and expectations, the data from the KC Cure folks is tremendous and very helpful for us. They've surveyed over 1,000 patients and gotten their perceptions on what they like, what their goals are, and they favor things like long-term response and the chance to live without cancer. So in their patients' perceptions, we always need to take those into consideration. So we want to thank KC Cure for obtaining this data. And then, we'll get into the next session, which is a panel discussion about what we would do for our patients.
Excellent, David. Terrific. Thank you so much for that. So we've got a couple moments here for what I like to call zingers, tough clinical scenarios. But before I get into that, David, we've seen these updates to Checkmate 214, and one of the things that I've heard you and Tom Powles and others speculate on is the number the number of at risk at the bottom of those Kaplan-Meier curves. And clearly, as you would expect, as time goes on from year 4 to 5 to 6 to 7 and so on, that number diminishes over time. At what point do we really lose the ability to infer much from these curves, or do we at all? Are they still useful out to 8 and 9 years?
I think the general trends are useful, particularly as it relates to overall survival, because it's easier to track someone alive or dead versus progressed or not. I think part of the problem with following patients this long is it's very time-consuming and costly to measure scans, for example, after a certain period of time, and patients often don't want to come back to be scanned. So the PFS data is probably somewhat less reliable because we're scanning people less at that point and we're losing patients from being scanned. But the OS data is probably pretty solid, and it's, obviously there are fewer patients out there, so we shouldn't make dramatic conclusions. But I do think what we see on the studies is what we have seen in the clinic. Is we all now have patients who are not just alive, 5 and 10 years later, but they're alive, some of them alive off treatment. So there are always limitations, but I think we should be in the future designing studies with the anticipation that we're going to have to track this information better. And like Tien has a study where this is going to be an issue, like, for your pedigree study, how do we follow these people over time to make sure we capture their experience at all of the different stages of that experience? I think part of the issue with these studies is they weren't designed with the anticipation that the outcomes would be so important, it would be impressive. So that's another thing we have to take into consideration. So for example, when you think about quality of life, we were not checking it, months after patients stop treatment.
Right.
And we should be, because it's then that their quality of life is probably the most impacted by being off treatment. So there's a lot we can learn. It's a good problem to have compared to where we were, but going forward, hopefully we can do better at measuring these things.
Yeah, well said, well said. It's something I kind of struggle with. We have 2 cases listed here. The second case, Janice, the 72-year-old with aggressive disease, hepatic metastases, and so forth. They say there that this patient presented following nephrectomy. Let's envision a case in which this patient still had their primary site intact. Tien, in this day and age, let's say you were going to start this patient on Nivo-IPI, or maybe make it a little bit more complicated, Cabo-Nivo. What would you say in the context of cytoreductive nephrectomy for a patient like this?
So I think it's a great question about timing of cytoreductive nephrectomy. Usually for somebody with aggressive disease, symptomatic disease, we would give systemic treatment first in the days post-Carmina. There is an ongoing trial called PROBE that I hope we're all thinking about when we're seeing patients with de novo metastatic disease in our clinics and starting them on treatment for early disease control. Because I do think that patients, as they have systemic disease control, their primary tumors are still full of potentially resistant tumor cells. And so in my practice, I am thinking about that. Once they've achieved good systemic control, then we're thinking about the cytoreductive nephrectomy to take care of the primary. And that practice may differ from center to center, from physician to physician, from surgeon to surgeon. Some like to wait 6, 12 months. Some, right at 3 months, they want to see it. And have that conversation ongoing with the patients for the right timing. But PROBE is cytoreductive nephrectomy at that 12-week mark, and within that 3 to 4 month window, getting those patients to the nephrectomy. So I hope we're still enrolling and able to answer that question so that we have more data in the future.
And how about the nature of systemic therapy? How does that affect your decision making there? Let's say this is a patient on TKI, IO. Does that make you a little bit more reluctant to jump into cytoreductive nephrectomy once they're achieving a reasonable response to therapy, or are you still comfortable with it in that context?
I have probably more than a dozen patients at this point in my practice who we have a trial with IVC thrombus, for example, with lenvatinib pembrolizumab, where they go into a nephrectomy after. We have patients in standard care also who have achieved good systemic responses, and we've worked with our surgeons to get them to nephrectomy. Now, if they have measurable disease after cytoreductive nephrectomy, those are the patients I might restart on their TKI that was controlling disease pre-op. But those are the nuances of that conversation of whether or not they need their primary out, particularly if they're symptomatic, that primary is bleeding or it's painful. Those are the patients that we try to take for nephrectomy. And in our institution, our surgeons are pretty aggressive, so they'll happily remove the primary if we ask.
Makes sense, makes sense. Patient number 1 here, Marty, the 67-year-old, had nephrectomy, but one thing we haven't chatted about here is adjuvant therapy. We don't have too much time on the agenda today to really do a deep dive there. But David, let's say that Marty had a high-risk tumor up front, right, and got adjuvant pembrolizumab, as many patients are these days, and then actually progresses while on adjuvant pembrolizumab therapy. Let's say this happens 6 to 9 months, and I'm seeing a fair amount of this in my practice. What do you do in scenarios like that?
Well, I think your trial, Contact 03, others since then, T-Nivo2, would suggest that switching to PD-1-based combos doesn't make a ton of sense in that scenario. So something that does would be to just switch mechanism of action and target VEGF if someone growing through PD-1 You could make an argument in someone who progresses after PD-1 to add CTLA-4, because there's some data that CTLA-4 will rescue maybe a small number, 10, 15% of patients who progress on PD-1, but not in the case that you described, meaning in someone who progresses through PD-1, they probably have an IO-resistant tumor. They either need VEGF or a clinical trial, I would think.
Maybe give us a timeline for that then. So in Marty's case, he's on adjuvant pembrolizumab. How long would he have to go without metastatic disease before you might consider sort of adding on ipilimumab in that context, or switching to Nivo-Ipi?
Right, so if someone progresses, I mean, some of this is arbitrary, we don't really know, and we need to do studies in this space, so we don't have to answer questions we don't have information about. But I would say at least 6 months off PD-1 before, it's justifiable to choose, to consider a re-challenge, because there are probably some patients who need chronic PD-1 blockade.
Okay.
And in those patients, so if they progress when coming off, there's probably a subset who will regain some disease control. I think PD-1, CTLA-4 salvage makes as much sense as anything to try in that setting, but for people who are truly refractory to PD-1, I don't think CTLA-4 is going to do much in that salvage setting, particularly if they're symptomatic.
Yeah, that makes a lot of sense. And Tian, let me ask you, David touched on some of the subcutaneous data. Are your patients starting to ask about this in clinic now? Are they receiving it to any significant extent?
I haven't had a patient ask for it, but I certainly know the limitations of chair time for sure in our infusion clinics, and so maybe under consideration as we think about how can we open up some chair time and infusion time for our clinics.
No, I agree with that. I think that's what's going to drive the usage. It's not going to be so much doctor-driven, but it's good to know that if the pharmacist asks, can we switch to this, that the data exists to suggest it's pretty similar from an efficacy point of view.
Makes perfect sense. Makes perfect sense. I'll throw this last one to you, Tian, as well. So a patient comes in, they note having, let's say in this case, 4% sarcomatoid disease. And would that percentage of sarcomatoid elements influence your choice of therapy at all?
Yeah, I think the sarcomatoid subsets on the big phase 3 trials were all just generally plus or minus, presence or absence of sarcomatoid disease. But those patients certainly do respond well to our immunotherapy combinations. Ipi-Nivo had the largest complete response rate in 214, about 18%. So, that's pretty compelling data. But if they were very symptomatic, needing early disease control, I might still lean on a TKI-IO. But certainly it's in my mind to lean more toward Ipi-Nivo for anybody with a sarcomatoid component.
Yeah, that makes sense. That makes sense. Well, I think we're going to jump right into the second portion of our dialogue here around strategies for refractory disease. So Tian, I'll turn it over to you.
Great. Thanks, Monty. Thanks to everybody in the room tonight. Always a privilege to present with Dr. McDermott and Dr. Powell, friends and colleagues across the country. I thought we would start with pedigree, which I presented earlier today, sort of as a continuation of first-line treatment to think about how do we sequence our immunotherapy doublets. This schema, I hope most of you are familiar with, all intermediate and poor risk disease, metastatic disease without prior systemic therapy, treated with step 1 induction of ipilimumab and nivolumab up to 4 cycles, followed by step 2 that's adapted for radiographic responses at 3 months. CR patients receive nivolumab alone, progressive disease receive cabozantinib alone, and patients with stable disease or partial responses are randomized to nivolumab with cabozantinib or nivolumab alone. Our primary endpoint was the overall survival of the randomized cohort, and importantly that it addresses this question of how do we optimally sequence our immunotherapy doublets for patients with metastatic kidney cancer. And this is a snapshot of the patient characteristics and disease characteristics that we presented earlier today. We enrolled over 1,100 patients in step 1 at over 500 sites across the US. This was carried out through the Alliance Cooperative Group. And of those more than 1,100 patients, 67% enrolled to step 2, of whom 597 were randomized. 141 patients were treated on the progressive disease cohort, cohort with cabozantinib alone, and then 9 patients were treated on the complete response cohort with nivolumab alone. This came up as a question after the talk with the single-digit complete responders. And as you see, we have a bit more patients with de novo metastatic disease, for example, in which those primaries don't shrink to 0, and as well as more patients with bone metastases. And so this was a more real-world patient cohort where we weren't expecting maybe to see those early complete responses. But the patient characteristics are seen there. Age and gender splits were very similar for US populations. We enrolled a pretty diverse patient population. Over 10% were Hispanic, Latinx, as well as over 8% were Black, Asian, or American Indian. And so those characteristics did not differ between those patients who discontinued in step 1 or patients who went on to step 2 treatments. In the disease characteristics, though, we saw differences across IMDC criteria, as well as the presence of bone metastases for those patients who discontinued in step 1 and those patients who went on to step 2. So of note, fewer patients with poor risk disease, as well as fewer patients with bone metastases went on to receiving treatment in step 2, and this was statistically significant. The presence of de novo metastatic disease, or where they were enrolled, setting of enrollment did not differ in those cohorts. So this leads us to thinking about refractory disease and how are we thinking about disease once patients are progressing on their frontline therapies. This sequence has now been developed a few years now. We've been talking through this in terms of the guidelines that we put out through ASCO a few years ago, but I think it still has a very pertinent role here in our daily practices. So if they've received a pure IO-IO combination in the frontline setting, we're often following those patients with VEGF TKI monotherapy. If they've received VEGF with immunotherapy combinations in the frontline, we're giving them an alternative VEGF inhibitor to David's point earlier, not adding back the PD-1 inhibitor. And then if they've had a VEGF TKI monotherapy, we're sequencing nivolumab or an alternative TKI. And I do think it depends very much on your patient, that first-line treatment and timing of resistance. So how should we think about therapeutic selection in refractory disease? There's a lot of patient-specific considerations, such as the mechanism of their frontline therapy, how deep and durable was their responses, and how rapid was their progression, and how are their tumors progressing? So is there a lot of disease burden, or are there oligomets that are progressing at the time of resistance? In terms of patient factors, their own age and performance status might impact your treatment selection in the second line, how symptomatic they are, whether they had significant toxicities, how would they manage those toxicities from their frontline therapy, and what comorbid conditions are present in terms of selecting alternative TKIs for patients with heart disease, for example. And it is still a shared decision-making all along the way. We talk about their goals for treatment, what their prognosis is, and what their understanding is. Now with refractory disease, what's their tolerance for risk and toxicity, and what support system do they have to come back and forth to the treatment centers. One of the trials that Dr. Albigez did in France a few years ago now was called Cabo Point, of looking at cabozantinib monotherapy after either IO-IO, Ipi/Nivo frontline therapy, cohort A, or IO-TKI, cohort B, followed by cabozantinib at 60 milligrams daily. These were their results from cohort A, objective responses over 40%, cohort B, 27%, a little bit of a difference in terms of patients who received IO-IO, so TKI naive, having a higher response in those patients seeing cabozantinib monotherapy. Also, we'll keep that in mind as we look at the other trials we have. TiVo-3 was the registrational trial for tivozanib in refractory renal cell carcinoma. It's a potent VEGF TKI that inhibits VEGF receptors 1, 2, 3. You're seeing the progression-free survival curves here, which was the primary endpoint of TiVo-3, and that favored tivozanib over sorafenib, has a ratio of 0.62, which carries out throughout the duration of follow-up. So as we're thinking about therapeutic selection in refractory disease, we're also thinking about, immune checkpoint inhibitor rechallenge, and we'll delve into some of the trials that we alluded to earlier, demonstrating not rechallenging these people with PD-1 inhibitors. Can outcomes be affected if non-checkpoint inhibitors were used before a rechallenge? So what's that break look like, and are there ways to reactivate T cells that are exhausted? And then are there any differences between anti-PD-1 or anti-PD-L1 therapies when we're thinking about rechallenge? So here are some of the combination data to support these. These two are non-randomized trials. The top one is phase 2 Keynote 146 with lenvatinib and pembrolizumab in patients with IO refractory disease. These are all checkpoint inhibitor pretreated patients. The objective response rate was about 56%. You're seeing the waterfall plot here. Some of them, there were 22 patients in this cohort that were treatment naive, but most of these patients were ICI pretreated, over 100 patients here. And then the non-randomized T-Nivo was a safety, essentially, cohort for the combination tivozanib and nivolumab, 62% objective responses for previously treated patients. Those set up T-Nivo-2, tivozanib with nivolumab. We saw those data about a year ago now. No benefit in progression-free survival of adding nivolumab to tivozanib in the refractory setting. This is the intention to treat population there you see. And then CONTACT-03 of cabozantinib and atezolizumab compared to cabozantinib. Again, no improvement in either overall survival or progression-free survival in these Kaplan-Meier curves. And so the take-home message from these two very large phase 3 trials was that immune checkpoint inhibitor rechallenge should not be generally undertaken given the IO sequence. Now we will see a subset analysis of CONTACT-03 in the poster session. Dr. Suarez is presenting on Monday, looking at those subsets of patients who've received IO or IO-TKI in the frontline setting and their subsequent objective responses. So stay tuned for that at ASCO. There is also, so that's on the right here, the subset analysis from CONTACT-03, and of those 522 patients, the subset was about 107 in the cabozantinib arm and 129 in the combination cohort that received prior IO or IO-TKI. And the conclusion still is that cabozantinib is pretty good. We didn't see any differences in the intention to treat population. We're not going to see much difference in this subset analysis, but I think looking through those and thinking about the objective responses for patients treated with cabozantinib controls will help guide our cabozantinib use in the refractory setting. On the left, you're seeing T-Nivo-2 subgroup analysis. This is being presented by one of Monty's mentees, Dr. Chirazi Raffel, also in the poster session on Monday, looking at subsets of tivozanib and nivolumab in the second-line setting for patients who had had prior IO or IO-TKI. 153 patients received prior IO, 83 patients previously received IO-TKI, and tivozanib monotherapy still also showed a good tumor reduction and therefore holding up as that control cohort. So I think both subset analyses will guide us for refractory TKI use in the refractory setting. It wouldn't be a refractory talk without talking about the evolution of HIF-2 alpha inhibition in kidney cancer. This is one of our favorite stories at UT Southwestern, as the first small molecules and their in the inhibitory effect of HIF-2 was discovered on campus, and over a long period of time it was thought that HIF was not targetable, and so this is a remarkable development, clinical development story that we won't get into, but certainly belzutifan now is approved in the US for von Hippel-Lindau associated diseases such as kidney cancer, pancreatic neuroendocrine tumor, as well as CNS disease, hemangioblastomas, and then also for advanced kidney cancer after IO therapy and VEGF therapy. And we're going to see the longer-term follow-up from LIGHTSPARK-004, the VHL disease-associated tumors, at the oral session tomorrow. Here's a look at the registrational trial of belzutifan in refractory kidney cancer, LIGHTSPARK-005, randomized patients with refractory kidney cancers to either belzutifan or everolimus. Saw objective response rates of about 22, almost 23% with belzutifan, much improved over 3.5% with everolimus. Progression-free survival was also improved, but of note, these curves crossed around the 3-month mark. And so you're seeing here that there are some patients who are refractory to belzutifan, but if they are responding, they're responding in a longer-term way, in a more durable way, and certainly responding better than those patients treated with everolimus. Overall survival in this trial was not statistically significant, but PFS was the main co-primary endpoint, and belzutifan was approved from 005. So what about a combination approach? Belzutifan with a TKI, the LIGHTSPARK-003 trial had a combination of belzutifan with cabozantinib. Here the objective response rate was 31%, and you're seeing the swimmer's plot for some of the patients who continue on belzutifan and cabozantinib. And it sets up very well the LIGHTSPARK-011 trial of belzutifan plus lenvatinib versus cabozantinib in the refractory setting. So that trial is fully accrued, and we're awaiting outcomes there. There's a new kid on the block called casdatifan. We have seen some monotherapy data for casdatifan in the dose escalation and dose expansion cohorts, and there was some good clinical efficacy seen with the casdatifan monotherapy, 25% objective responses at the 50 milligrams twice a day dose, 29% objective responses at the daily dose, and 33% objective responses with 100 milligrams daily. And so that sets up the combination cohort of casdatifan with cabozantinib expansion cohort, which we'll see on stage tomorrow, which is the expansion phase of ARC-20, and we'll see that at the oral session. Very exciting to see the combinations come together, setting up the phase 3 trial called PEAK-1 that's currently in early clinical development and being pushed out to open soon across all of our sites, I think, with casdatifan and cabozantinib versus cabozantinib in a 2-to-1 randomization in refractory kidney cancer. So how do we understand our patient's viewpoint? I think all these data from Dina Battle and Casey Kure are really helpful to helping us think about how patients are thinking about their disease burden and their mental burden and their anxieties and worries with metastatic disease. So this is a survey of more than 1,100 patients with metastatic disease and undergoing systemic therapy. I think the bar graph on the bottom is really interesting to see people thinking about their treatments and impacting eating, for example, 37%, impacting sleeping, 38%, and their daily lives, right? And so disease burden that's experienced by our patients with kidney cancer, especially on treatment, is quite excessive, and future treatment developments should think about considering that mental load and disease burden in addition to our usual endpoints of PFS and overall survival. And then I think we're back to our case. Monty, I'll turn it back.
Great job, Tian. That was wonderful. Thank you for that. I'm going to first turn to probably the number one question I get from colleagues in the community, and that's around managing belzutifan toxicity. Right. So, let's say we have Marty over here who initiates first treatment with Cabo-Nivo, then let's say he gets tivozanib in the second-line setting and then goes on to belzutifan afterwards. Let's say his hemoglobin at baseline is pretty typical, I would say, in the third-line setting, is a little bit rocky. Let's say it's around 10 or so, right? And you see that hemoglobin slip down to 8, 7, kind of in that range. David, what are you doing in that setting? Are you dose reducing? Are you thinking about growth factors?
It partially depends on the symptoms. So if the patient is mildly symptomatic, most of our patients, as you know, deal with fatigue all the time. But if they have nothing beyond that, we usually try to treat through, but add EPO in some form. We usually give darbepoetin for patients.
Okay.
And what we found is, it works really well because one of the HIF targets, as Dr. Brugarolis knows in the background there, is EPO. So EPO levels fall, particularly in responders. So replacing EPO works pretty well. And also you don't, at least in our experience, you don't need to give it as regularly for a HIF inhibitor patient as you might for, say, a dialysis patient or something like that. So one dose will often carry them, longer than, say, a 2 or 3 week interval. Sometimes we dose it every 3 months or something like that in patients. It often works quickly, works for a long time, and allows us to get away without reducing the dose.
Well, let's say instead of anemia, Marty's suffering from the hypoxia that's noted occasionally with the agent, right? So, he starts out with a great baseline O2 sat. He's in the, high 90s when he comes to you initially. You start him on belzutifan, and then you see that O2 saturation drift down. What's that cut point for you, Tian, when you say, okay, we got to put this medication on pause?
Yeah, I think doing the walking sats are helpful and take some time, but we've been walking them around the clinic, and if they go down below 92% on room air, I think it's the moment to think about adding some supplemental oxygen, especially on exertion. If they're in the 80s, I think it's time to take a break, and we might dose reduce, for example.
Same for you, Dave?
We're a little bit more aggressive. I understand the concern because obviously those numbers are scary. They're particularly scary for the front office staff because they're the ones doing the pulse ox, and they come back to you with, Mrs. Smith's pulse ox is 78, that kind of thing, and usually creates a commotion. But most of my patients in that scenario are pretty asymptomatic, believe it or not. We're usually more symptomatic than they are with anxiety. So to Tien's point, if you can exercise them and it comes back up, we keep going. Oftentimes we do central O2 sats, so we check it on the center of the forehead, and that's usually often better than the peripheral. And once again, it's based on symptoms. So if the patient's benefiting and is asymptomatic, we tolerate a lot of at least pulse ox hypoxemia in the clinic without reducing the dose. I've yet, this isn't wood, but it looks like wood. I've yet to have a patient have a pulmonary, I know there have been reported complications, but we've yet to have a complication, even though we've seen patients with scary SATs in the clinic. Now, where it gets tricky is if they have other baseline pulmonary issues. So if they have, low SAT and COPD or bulky lung disease or something like that, so when you can't tell exactly what it is, then it's a little trickier. But we're more eager to treat through than the package insert suggests.
That's brilliant. I didn't think about measuring that O2 right
Try
there.
it next time.
Yeah,
Yes.
absolutely. Well done. Okay. Tian, tell me about your monitoring on belzutifan. So, you have that patient come in for their initial consultation, you're going to put them on the drug. How often are you checking their hemoglobin? How often are you asking them to check their oxygen levels?
Well, I'm usually checking, blood counts every 2 to 3 weeks as they're getting started. And then, as they're in the clinics, we're checking their pulse ox. But some people, ambulatory pulse oxes are easy to get. And so we'll ask them to have one at home. And if, we start seeing values in the 80s, come on in, let's check you out, even before that scheduled 2-3 week visit.
Okay, fair enough. No, that's really helpful.
What do you do, Monty?
what do I do in that context? You know, I do ask them to monitor their pulse ox at home, and you know, again, if they see that slipping down, usually below 92, maybe I have a lower threshold. You know, I'll bring them in, or suggest at that time they stop the drug for a couple of days and check in with them, you know, to see whether or not that bounces back. And inevitably it does. I mean, in most cases, you know, it just bounces right back, and then I'll usually contemplate dose reduction thereafter. I will say, though, that, you know, after talking to so many colleagues in forums like this, you know, this is one of those areas, management of anemia with belzutifan, management of hypoxia, where everybody has a slightly different management strategy. So it's good and bad. Worries me a little bit, I suppose, but we
learn from each other.
Right, absolutely. You know, David, I'm going to throw a tough one at you here. So a patient comes to see you. He's been on Nivo-IPI already, progresses on that, and his practitioner, not you, is, you know, seeing the contact-free data, puts him on Cabo-Nivo.
Yep.
Okay, and this patient's actually having a great response to Cabo-Nivo. Let's assume he's tolerating it reasonably well, maybe with grade 1-2 side effects for the most part. Is your advice to that patient to actually stop Nivo in that context, or would you just recommend that they continue if they're responding well?
Yeah, patients, particularly with PD-1, where they're not getting cumulative toxicity, they're not big on stopping, particularly if they think it's working. So, you know, so I think in that scenario, it would be hard to pull it away, because if they ever progress, they would come to you and say, "What did you do to me?" But to your larger point, it's probably not helping, you know, based on your contact 03 data. Cabo alone is almost certainly just as good for that patient as Cabo-Nivo would be, unless they came off the prior PD-1 for some other reason rather than progression. So if they came off for toxicity or something like that, or, you know, they wanted a treatment break, you know, those are uncommon scenarios.
Yeah, you know, and I feel this is something we've gone over a fair amount in years past, but it's always worth readdressing. You know, let's say your patient starts on Nivo-IPI in the upfront setting, TN, you know, they're ready for second-line treatment. What does that decision-making look like? Are you consistently going to one therapy typically in that setting?
For me, it really depends on how long they've been on Nivo-IPI and the maintenance phase of Nivo. If that's been a long time and if they initially had a response, I might think about, let's take you off for a while. Let's try cabozantinib in the second line, but maybe in the future we might circle back again, right? I don't know that we've addressed all the sequencing questions, and I do think sequencing life-extending therapies overall will add to our patients' lives. But maybe they need a break because they are now PD-1 refractory. If they are refractory right away, right within the first 3-6 months, then I go to VEGF TKI straight away.
Okay, that's fair. Yeah. And Dave, what about for that patient that starts on TKI IO? Let's say they start on Cabo-Nivo in the upfront setting. What are you thinking about in the second line setting in most cases?
In most cases, I would have started the VEGF TKI because they had a high burden of disease and were symptomatic. So I'm probably going to switch them to a second, TKI in that setting. Although I think that one piece of data that I think is interesting was that the belzutifan team did a study with introducing belzutifan a little sooner in the course. And it probably works better the earlier you give it. So the less VEGF exposed the patient is. If they're not VEGF exposed, it probably also works somewhat better. And patients generally prefer to be on belzutifan from a quality of life standpoint because the toxicity profile is more narrow. So if they don't have a high disease burden in that scenario, I will try belzutifan earlier. Symptomatic patients, though, probably need a second VEGF, hopefully at a different dose than what they were tolerating before,
Yeah.
Try Lenva or Tivo in that scenario.
And this is maybe a bit more of a provocative question, but it does lend itself to the last bit of our talk here. Patient progresses on Cabo-Nivo in the upfront setting. Is that a setting in which you'd be comfortable offering the patient a phase 1 clinical trial, something that, is first in human, maybe in the phase of dose escalation, probably more often in the phase of dose expansion? Is that something you would think about second line for a patient? Maybe Dave, I'll start with you.
I think you could, depending on the goal of the trial. So if it was one of your exciting CAR T-cell trials, sure.
Okay.
You know, because there's a chance there, as you've shown, of a durable benefit that might last after the treatment it stops, number one, but also that that's an intensive approach. It's not proven, so they have to be in decent shape to get through it. So if they're doing something that aggressive in that setting that's fourth or fifth line, it's going to be much harder. You always, regardless, if the patient is asymptomatic, you always have the opportunity to salvage them with the things you haven't used afterwards. So at least I would discuss it with patients.
Yeah. How about you, Tian?
I think so. You know, I think it really depends on the patient and their tolerance for, you know, experimental therapies. But we have some patients who say, no, thank you. And then some that say, hey, you know, I know my options are somewhat limited. Let me think about what options are available on trial. You know, phase one, I think it depends on how many lines we think that patient's going to be able to see.
Mm-hmm.
You know, the patients with indolent disease that are probably going to see multiple lines of therapy, you know, maybe we do phase one a little later because there are multiple lines of known life-extending therapy. But if there's a really exciting molecule that we see early disease activity and we're like, hey, this is pretty comparable to others that we've seen in this setting, you know, second, probably third line would certainly be open to putting them on.
Yeah, it's something I think about a lot because I feel like this is a major impediment for drug development in kidney cancer in the sense that, you know, many times we're, you know, putting patients on seventh and eighth line therapies with novel therapies and then dismissing them when they don't work. And of course, at that point, you know, we're probably treating a really sort of anaplastic phenotype, something that doesn't at all resemble the original tumor. So, you know, I appreciate that. I've certainly been trying in my own practice to sort of sequence in phase one trials a little bit sooner. Very good. Okay. And then we're going to move in right after this, right into the last section of our presentation today, which is, I think it'll be pretty exciting. We'll talk about some of the data that's hot off the press from this year's ASCO meeting, including data presented today. And in fact, that includes this agent, zanzalintinib. So zanzalintinib is a novel tyrosine kinase inhibitor, and I do think that, and we'll see this in the context of its clinical activity, it really differs from what we have in our arsenal currently. You can see that it's a TAM kinase inhibitor, VEGFR2 inhibitor, an AXL inhibitor, and a MET inhibitor. It seems to have a shorter clinical half-life, for instance, as compared to cabozantinib, despite having a somewhat similar target profile. And its PK properties are amenable to once daily oral dosing, and that's what you see in the context of the clinical trials. So this is some of the data that we've presented previously for zanzalintinib, and I think this was quite impressive. So this takes a population of patients that actually includes individuals that have previously received cabozantinib to at least some extent. All patients had received prior VEGF TKIs almost, for the most part. The response rate in this cohort was 38%. If you take patients who had received prior cabozantinib, you can see the response rates documented on the right there, 24%. If patients hadn't received prior cabozantinib, that response rate climbs to 57%. If the patient hadn't received prior TKI, you can see that that response rate climbs up to 63%. So, you know, again, I mean, I think that this is a really compelling agent, and we've been waiting for a long time, I think, to see further iterations of this data, and today we had a chance to do that in the context of STELLAR-002. So this is a schema for the STELLAR-002 program. The first cohort that you see listed on the left there is comprised of patients with clear cell RCC, and patients were receiving either zanzalintinib with nivolumab, zanzalintinib with nivo-ipi, or zanza with nivo-rela. And we're going to focus some of our attention on the first and third of those subsets today. In cohort 2, again, this is second-line clear cell RCC. Patients in this particular context received either zanza alone, zanza-nivo, or zanza-nivo and rela. And then in cohort 6, there was non-clear cell data that was assessed. So at ASCO 2025, we got an update on this cohort 1 cohort. So this is treatment in the first-line setting. I was actually quite impressed by this. So you can see here in this cohort of 40 patients, we have a response rate that exceeds 60%. You know, I'd summarize that if you looked at the tox profile for this agent, and this is my own conjecture, I would suggest here that maybe there's a little bit more in the way of hypertension, but less in the way of some of the day-to-day side effects that really sort of plague us in the RCC clinic, less in the way of diarrhea, less in the way of hand-foot syndrome, and now having treated a fair number of patients on some of the Zanza programs, you know, that's generally mirroring my experience to date. So I am kind of excited to see avenues for Zanza/Nivo moving forward. I think that response rate of 60% is very laudable. And that really segues us into a discussion around non-clear cell kidney cancer. And we're going to come back full circle to Zanza/Nivo in just a bit. So non-clear cell kidney cancer is something that I've really been quite focused on, along with my colleagues up here on stage for a good part of my career. This comprises about 25% of all RCC subtypes. And in general, this unfortunately hits a younger population of patients. You can see this beautiful schematic here. I think this was an article done by one of Dr. Pavlos Masul's fellows at MD Anderson. And he's subsetted out patients based on chromophobe histology, type 1 papillary RCC. Some of these designations have been modified over time, unclassified RCC, and so on. I think the key with a slide like this is to recognize that there's different biologic drivers for each of these. So if you look at that fourth row over there of molecular alterations, you see, for instance, that papillary renal cell carcinoma is driven by MET. You know, we have other subsets that are driven by unique entities. So this isn't by any means any sort of molecularly homogeneous disease cluster. These are all very, very distinct subtypes. We just finished up accrual to Stellar 304, so this is a randomized phase 3 experience. I think this is much needed. So this included patients with unresectable and advanced papillary, unclassified, and translocation RCC. Those of you that were in the session today saw a trial done by the Children's Oncology Group looking at translocation RCC specifically. And this was really an aggressive effort within that very rare histology. But that particular trial, after many years of effort, I'd constantly see it presented at our SWOG meetings, really managed to only accumulate about 20 patients. And, you know, it's a challenge that we face in non-clear cell RCC. So I'm just really thrilled to, have finished this particular experience. So again, this was a randomization between zanzalintinib and nivolumab to sunitinib therapy. This has the dual endpoint of progression-free survival and overall response rates. So what's the justification for a comparison against a TKI plus IO? I think there's some compelling data. The thing that I would emphasize here is that these are all single-arm experiences. So if we look to the first cabo-atezo, this is a program that I was involved with. If you actually tease out, just for the sake of comparison, the subset of patients with papillary RCC, the response rate in this cohort is around 47%. It's interesting, if you move to the right to cabo-nivo, the response rate there, again, right around 47% in the papillary cohort. If you look at bevacizumab and atezolizumab, response rate falls a little bit, right? This is a regimen that hasn't been as active in the context of even clear cell RCC. So the response rate there for papillary is around 15%. With len/pembro, we see a response rate of around 53%. So they're all kind of in the same ballpark. But again, you know, in these single-arm experiences, there's very careful patient selection. This doesn't necessarily mimic real-world practice. I do want to encourage you to take a look at a trial called the Fortune study, which is led through the DoD consortium, and this is actually looking at yet another potential combination for non-clear cell, and that's tivozanib and nivolumab. So what do we have outside of the context of the single-arm trials that I just described, looking at TKI plus IO? So I scratched my head a little bit around this trial, Sunny Forecast. This was definitely an aggressive and I think laudable effort from a European group. And what this did is it looked at patients with non-clear cell kidney cancer, took a very big hodgepodge of patients. We're delineating here papillary and chromophobe, but there's a large cluster of non-papillary subtypes that were evaluated there, as you can see. And it randomized them to sunitinib or nivolumab and ipilimumab. The primary endpoint in this particular study was 1-year overall survival. And I'm really struggling to think of other trials in our disease that have really incorporated that endpoint. It's a very unusual endpoint. If you look across responses across categories, I will concede that there might be a slight advantage with nivo/ipi over sunitinib in some cases, certainly not all. But I will say that when it comes to overall survival, to PFS in the overarching cohort within this study, we really don't see any significant advantage. So this particular trial hasn't really moved the needle for me. I will be stopping by the poster tomorrow to see how this has panned out since. But you know, in my mind, I don't think this is something that I've necessarily incorporated much into clinical practice. One thing that we're really excited about is actually presenting some data related to the microbiome. Two of my outstanding fellows, Dr. Disman and Dr. Ibrahimi, reported out the data sets that you see in the top left and top right, looking at nivo/ipi and cabo-nivo in combination with a live bacterial product called CBM-588. Now, these particular trials evaluated CBM-588, and the primary endpoint across both was actually a biologic one. We were looking for changes in the gut microbiome. But what we saw, despite not necessarily seeing that initial change in gut microbiome status, was what I thought was a fairly dramatic clinical effect with both of those particular studies, and that's migrated into a SWOG proposal. We hope that'll launch, we're hoping Q3 or Q4 of this year. They'll incorporate all TKI backbones and randomize patients to that with either placebo or CBM-588. In the bottom left, one of my fellows, Dr. Zugman, is actually updating some of the data pertaining to both of these cohorts, Nivo-IPI with CBM and Cabo-Nivo with CBM. You'll be able to see that in the poster, but just to spill the beans, we actually do see a persistent effect from Nivo-IPI and CBM in our analysis. If we're not thinking about checkpoint inhibitors, then what? Dave was kind enough to give a shout out to these studies just a moment ago. We're very interested in, I think, within the whole investigative community in RCC and other diseases, solid tumors, of taking the success that we've had with CAR-T and the hematologic malignancies and translating it to our diseases. This is a CAR-T cell directed at CD70, which is a very pervasive antigen in renal cell carcinoma. You really don't find it in a whole host of other diseases. Cutaneous T-cell lymphoma is another state in which you see a lot of this. Having said that, with this particular CAR-T construct, I wouldn't say this really would represent a sea change in therapy, but we did have one patient with a durable complete response that's lasted 4.5 years. So there is that potential for some of these early phase studies to really have transformative potential. And I was planting this scenario a little bit, but one thing that I'll mention is that the reason why I've started considering phase 1s for a second line is that that patient who had this durable CR had only received therapy with cabozantinib and atezolizumab in the upfront setting on a clinical trial. There's other CAR-Ts in pipeline. The one on the left I think is just fascinating, AB2100. This is actually a dual CAR-T expressing both PSMA and CA9 directed antigens. And what I think is really interesting about this is that there's conditional expression. So the PSMA is intended to really drive the CAR-T towards tumor vasculature. CA9, of course, is there for cell kill. CA9 is an antigen that's fairly pervasively expressed in renal cell as well. So I'm really excited to see how novel CAR-T strategies like this pan out. In the bottom right, you see an ongoing assessment of a compound called ADI-270, which, much like CTX-130, is a CD70-directed CAR-T, but this is utilizing a gamma delta T cell. In the top right here is a phase 1 clinical trial that's going to be reported out regarding the TRAVERSE study. The TRAVERSE study is actually one looking at ALLO-316. This is another CD70 CAR-T. Interesting data. When you guys see the oral presentation on Monday, it'll reflect, Sunday, excuse me, tomorrow, it'll actually reflect a cohort of patients with high CD70 expression. And within that subset, there is a respectable response rate of around 30%. Of course, I think in all these studies, it's very important to consider toxicity. Okay, so we have an opportunity here to ask some questions. I've got a couple that are actually coming up in the queue here. So with that, these are actually really good ones that are popping into the queue. Maybe I'll stick with these as opposed to going to my zingers.
I prefer that.
Yeah, great. So, we have belzutifan. We have the data for casdatifan. Is there space for 2 HIF-2 inhibitors in RCC? Dave, what do you think?
Yes, sir.
Yes, that's it. Okay.
Well, yes. I mean, without being, too negative, I think let's just say for the sake of argument, they're equally active. The strategy that company A seems to be pursuing is to, belzutifan is now approved, let's move it up earlier in the schema for treatment in combination with other things. Second line setting with TKI, first line setting with triplets, even now in the adjuvant setting. Some of those approaches have data supporting them, others not much. So the PD-1 HIF combination, there's very little data to support that is a good idea, but yet it's going into a randomized adjuvant trial. Another company involved will help because we might be able to then do other things, that Merck is less interested in. So for example, moving just single agent HIF inhibitor up earlier in the course of treatment potentially, or identifying a predictor of response to single agent, which would then facilitate bringing it up. Because, as Tian was talking about, there's the response rate to belzutifan is low, but those responders, a lot of them are very durable, and those patients often don't get worse toxicity-wise over time. So they pretty good quality of life. Imagine if you could do that as your second-line therapy, or even in a selected group of patients, potentially in your first-line therapy. That would be a real advance for patients, because I've had some patients on HIF inhibitor for years, and that's not a typical experience, with other targeted therapies.
Yeah, let me ask you, Dave. I mean, this target that we speak of for belzutifan, it seems a little bit elusive. Is there anything that you've come across that seems like it might discriminate between responsiveness to a drug like belzutifan versus, say, tivozanib, cabozantinib? I would imagine a lot of overlap, right?
You would think, it's hard to know for sure, because the patients who are out there getting belzutifan, in some ways, you're selecting for the non-belzutifan responders by exposing them. If you're right and there is an overlap, then giving 2 lines of VEGF is not great prior to belzutifan. The fact that you see even a 25% or 22% response rate in a heavily VEGF-exposed population is obviously, not great. Maybe it's better if you bring it early, but I think we need to see the tissue data before we sort of assume who responds and who doesn't.
Yeah.
So it could be, it doesn't, and some of the early work that UT Southwestern and other groups have done, some of the usual suspects that you might think might predict for benefit haven't yet.
Okay.
So we need to do better studies with better tissue that's obtained from the metastatic disease at the time you're treating the patient, that kind of thing, to come up with a marker. But I want to believe we can do a much better job of coming up with tumor-intrinsic biomarkers than we have with VEGF or PD-1, because those are, microenvironment markers, essentially.
Well, Jim's sitting in the back, and he's characterized beautifully 2 or 3 mutations in the HIF binding pocket.
Yep.
And I don't know if casdatifan has that preclinical data of, could it fit the groove with the mutations, right? So I'd be curious to see that. But to your point, if these trials with belzutifan are moving earlier in the disease course and patients are progressing after those, could another HIF inhibitor be an effective strategy in those patients? Well, if they have mutations and if casdatifan fits that binding pocket despite the mutations, then maybe. But I haven't seen any preclinical data to support or refute that.
Interesting. This is another good question that we actually didn't touch on. We talked about metastatic papillary kidney cancer, translocation to some extent in the context of these trials, right? But what about chromophobe? Tian, let's say a patient rolls into your practice with metastatic chromophobe RCC. What types of treatments are you leaning towards in that context?
Hard, very hard times, because you saw a little bit of responses for ipilimumab, nivolumab for in the Sunny Forecast trial for chromophobe, but generally these patients are not so IO responsive in my experience. We had some go on the CANI trial with cabo ipi-nivo. There were some responders on one of the Keynote trials with lenvatinib pembro in the non-clear cell setting, B61, I believe. And then, there's been some signals for cabo-nivo for that cohort as well. I've had some patients respond even to cabozantinib monotherapy. And then recently, there are some interesting phase 1s now for chromophobe where they actually express EGFR. So I've had a stabilizing of disease of a pretty refractory chromophobe patient with chromophobe cancer that we put him on one of the EGFR bispecifics, and it stabilized his disease for a bit. So maybe new targets are coming, and hopefully we're pushing those limits to find, strategies. I'd love to think about something that inhibits ferroptosis, for example. Lisa Hensky and others have really looked at mechanisms of ferroptosis in chromophobe kidney cancer. So I'm all for new therapies for chromophobe.
That's great. That's a lot more than I anticipated for chromophobe. I mean, that's a good array of options, I would say. I will agree with you in one particular regard. I tend to favor lenvatinib-based therapy. There seems to be something special in my mind as I look across, the small but emerging data sets, len-pembro, len-ev. There seems to be some signal in that particular disease. I may jump on this next question here, which is around bispecific therapies. In fact, Dave and I were starting to have a conversation about this before we walked into the room today. I don't know of a ton of bispecific trials out there for renal cell, but one that I've been involved in is looking at a bispecific directed at CD3, of course, and ENPP3. So ENPP3, through extensive target discovery, like CD70, is a very pervasive antigen in renal cell. That study doesn't have any data out as yet. It's ongoing, and that's one particular approach that we're taking using bispecifics. I don't know if there's any others that folks want to give a shout out to.
Not that have any data, but I think that's an incredibly interesting area in a variety of tumor types, and we've seen data across cancers with them. They have a much more favorable toxicity profile than some of the cell therapies that you've talked about. So I think not only could they get tested more easily in our patient population, but used eventually, potentially even in smaller centers. So we should certainly push for their development, I think.
Yeah, just to give folks a practical sense of what some of these CAR T therapies entail, typically we're giving 3 days of conditioning chemotherapy, which can actually be tough for some of our RCC patients who have more limited marrow reserve. And in terms of logistics, it can be quite complicated, right? We usually ensure that patients are nearby campus, which is challenging for us. We have a lot of patients who commute into Los Angeles for a period of about a month or so, in order to have really close observation and follow-up for any toxicities they might incur. Bispecifics, don't necessarily have that challenge of the lymphodepleting chemotherapy, or, they don't always necessarily have that challenge of tight observation for these extensive periods of time. But I will say that, many of the bispecific trials that I'm involved with are actually requiring, frequent hospitalizations for at least a month or two until some tolerance is built to the product. And then, visits can be spaced out thereafter, but the treatments tend to be fairly frequent for the most part. I haven't seen a lot of bispecifics that avoid that. And there's a lot of that data in public domain, for instance, in prostate cancer for the bispecifics that are being developed there. But it is a really, really interesting emerging field. Yeah, that's very interesting. This is a great question that I can't believe we haven't touched on. Usually it comes up earlier in our dialogue, and that's around the application of next-generation sequencing. When do you tend to get NGS in your patients, Tian?
Well, to be honest, there's no directly targetable lesion for kidney cancers, and so I don't get them, right off the bat, and because we have a number of proven therapies. But if something's not, responding the way I think we should be seeing for clear cell kidney cancer in particular, I might send it off. Or if they have a non-clear cell histology and we're kind of wondering about alternative strategies, we'll send off genomic testing as well. But I think more and more as we have some tumor agnostic labels and maybe ADCs coming down the pipeline that are looking for specific cell surface markers, maybe those are the time points where we're starting to think outside the box, find some molecular profiling earlier.
David, how about you, NGS?
So we don't send it, like Tian said, but sometimes it comes to us. Patients get it from somewhere, and we struggle to know what to do with it. Sometime there is a phase 1 that might be relevant, but it's pretty rare. But I think that's going to be an issue for us going forward as we go beyond next generation DNA sequencing and start seeing more reports with RNA, information. I think it wouldn't be surprising to me if companies start adopting that as the costs go down, and then what are we going to do with that information? Because there, with RNA signatures, we do have some more data in kidney cancer about what might be more or less likely to work. We're not close to a companion diagnostic in kidney cancer, but I do think we're going to be able to integrate some of these new technologies in some decision making, I think, hopefully, going forward.
Interesting. You know, as we were discussing this, it brought to mind a different question. This is salient to a lot of the dialogues we had today on the ASCO stage, which is KIM-1, right? And this is actually a test that patients can get in the context of kidney injury. So, you know, what settings would a KIM-1 level influence you? Let's say a patient doesn't walk in with an NGS test, but you're going to have that dialogue around adjuvant therapy. Would you even consider using their KIM-1 levels at this point to guide therapy? David or Tian, either one of the two of you.
I think not at this particular moment, but if we have CLIA certified, commercially validated tests, the more and more data is coming out, then perhaps we're sending it off and learning more about kidney injury molecule, and sort of stratifying and finding the high-risk population. I think in the adjuvant setting in general, we're trying to find that high-risk patient population at higher risk for disease recurrence to, you know, get the benefit of the year of pembrolizumab.
Yeah, let's say that KIM-1 level 0, David. That patient otherwise meets indications. I had to wrap up with a tough question.
Yeah, no, I hope I don't get patients like that. Although after today's session, we might get some more of them. But I mean, I think we need to insist on trying to confirm the value of that test in prospective trials, because Tian was, you know, talking about some of the benefits of that approach. I mean, it's a pretty simple test to do, so it can be done in almost any, you know, CLIA certified lab. It's inexpensive, you know, it's reproducible. The studies we've been talking about, many of them have been done on samples that are old and all that sort of stuff. So if we could confirm its value in any one of these settings, it could not just be applicable in our clinics, but around the world, you know, potentially. So it's not going to be easy to support those trials, but we need to push and I think it's probably most helpful in the short term in the adjuvant setting, you know, where we struggle to decide who should get treatment and who shouldn't, because we're probably not just over-treating patients in that setting, but we may be under-treating some patients as well. And it would be good to know who's who.
Well said, well said. Well, with that tough question, we're going to round out the program for tonight. All right, well, with that, thank you all for your attendance, and I hope you have a wonderful ASCO meeting. Have a good night, everybody.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Kidney Cancer Research Alliance. This educational activity is supported through medical education grants from AVEO Pharmaceuticals Incorporated, Bristol Myers Squibb, and Exelixis Incorporated. To access all materials for this activity, visit peerview.com/JUG860.